All right, and as you guys can see, the chat feature is live. Jim Mulpus, our director, will be handling the chat function on this call. So if you have any questions, we'll try to get through those as quickly as possible throughout the duration of the call. But if not, we will leave some time at the end of the call to go through some questions you guys have or offer them up to Dr. Rosen. If everyone can go on mute. Okay. And we'll send those along to her via email after this call. So looks like we're at 12 o'clock. So people might start trickling in, but let's go ahead and get started. This is a 30-minute call. So thank you all so much for being here today. We know the Roe versus Wade decision is a big topic on everybody's mind, and we wanted to bring all of our leaders together to discuss this timely issue in a fast-paced 30-minute call to review some immediate steps for consideration. So, as we all know, on Friday, June 24th, the Supreme Court overturned Roe v. Wade. I'm sure we're all in unique situations on this call, and we're all beginning to unpack the effects that this law is going to have on our individual circumstances. So for hospitals and health system leaders, there are immediate and critical impacts for the delivery of women's health services, regardless of where you are. Today we have Dr. Stacey Rosen with us. She's the Senior VP of Women's Health at Northwell Health Katz Institute for Women's Health in New York City. She's responsible for the comprehensive and integrative approach to women's health. So we want to thank her very much. She's very relevant to this call and this topic. So thank you so much for being here with us and discussing this important matter, Dr. Rosen.
Thank you for inviting me, Michelle. I'm delighted to be here.
Absolutely. So let's jump into our first question here. So Dr. Rosen, since you are in charge of women's health and you have such a unique perspective for us here today, we're eager to know how your organization has responded to the fall of Roe v. Wade.
No, it's a fascinating, complicated set of questions, probably one of the most complicated interdisciplinary challenges, I think, for a practicing physician like myself. I'm a cardiologist, not an obstetrician. It goes back to the important and overriding belief here at Northwell, and I think amongst doctors and honestly amongst 80% of American citizens, is that abortion services are an essential part of women's health care.
Sure.
And, as said by the UN and the World Health Organization and all of our academic organizations, safe, effective, proven abortion services is simply part of healthcare. And everything else that has made this a challenging and complicated issue, frankly, doesn't belong inside a doctor or clinician's office, in our emergency rooms, in our OR, and even in our financial challenges. So, the first thing is that none of this was a surprise to Northwell. And I think to institutions that focus on a comprehensive and integrated approach to women's health, reproductive health for women throughout their lifespan is something that has to be a priority.
Sure.
So, it has to have been something that is embedded in everything we do. So, it's something that we see women's health differently at Northwell, and it is outside of silos of obstetrics and gynecology, others, surgeons, finances, ethics, education, advocacy, lobbying as a health system. So clearly we have been geared up to optimize the health of women. So in relation to that Friday, Michael Dowling, our well-respected and visionary CEO and our chief medical officer, immediately put out a statement that we consider this to be a safe, reliable, and evidence-based part of women's health care. And also that intruding into the doctor-patient relationship is something that is, an unacceptable approach. Dr. Kalman and I wrote what we thought was a provocative op-ed piece that was prepared for months, honestly, speaking as two practicing physicians, what this could mean to us, and that this isn't just the hyperbole of issues. This is a patient of mine who came to my office after losing a pregnancy at 21 weeks because of undiagnosed cardiac condition, who inadvertently became pregnant while on contraception. And to be unable to have that conversation about all of her options and all of and hold her hand and guide her through is frankly an impossible situation to put the healthcare world in. And then thirdly, our service line head, our senior OBGYN, put out a very important set of guidelines and things that we are doing. We've got a very extensive family planning section within our Department of OBGYN that continues to offer these services. We are working with finance to be sure that we could navigate the expenses of abortion services to allow the access, and that cost should not be a deterrent. We are working with our legal office to be sure that this is something that we, despite living in New York, still do not find ourselves in in a position where healthcare decisions are made not by patients and doctors in a room. And we're also funding external needs for individuals who may need these services that have to come to us because they lack an opportunity to go elsewhere. And lastly, Dr. Nimroff is expanding our training programs, to be sure that, this is a technical and surgical skill,
Absolutely.
honestly.
Yeah, it sounds like you have a lot of strategy in place and communications are in place. Are there any, just for everyone who's on this call, are there any steps that are forthcoming for you guys down the road as we kind of navigate this law?
Yeah, no, I think that, with the goal of treating it as healthcare, I don't say it flippantly to say I'm a cardiologist. I can't imagine if somebody came to me and said that balloon procedures are no longer available to you, Dr. Rosen. Everybody has to go for bypass.
Right.
And I'm not implying that coronary disease is the same as an unwanted pregnancy, but to us as healthcare clinicians and providers, we honestly see it that way. So identifying the ways to, again, expand our care delivery model, expand access through financial studies and changes, other sorts of funding, and then continuing with, writ large, advocacy groups, women's health groups, legal organizations, all of the other partners, government, religious organizations, so that this is not a reactive, unaligned approach, but that this is an aligned, multi-centric approach to, what's an assault on healthcare, honestly.
Absolutely. That kind of leads me perfectly into our next question, which is what are the key partnerships that you guys are working with to keep these services available to people, whether it be outside of state lines for some of our listeners or organizations to partner with? Like, who have you guys contacted and are really keying in with?
Yeah, no, it's a great question. And I'm going to go back because, Northwell's Cats Institute is somewhat unique, but I think many health systems look at women's health. I'm practicing almost 30 years, and women's health to me at the start of my career was OBGYN.
Mm-hmm.
And then we realized, and more places are looking at this more expanded model that looks at the woman in the center of all of our healthcare initiatives and puts our clinical programs, research, community outreach, research around that woman. So our look, we always have our physicians, our corporate leaders looking at women's health differently. I practice cardiology, so the American Heart Association has two very critical guideline papers for me. One is about pregnancy and heart disease, and the other is about fetal intrauterine cardiac abnormalities, some of which sadly make life expectancy not likely. So our college and my heart world, I have had to deal with pregnant women, how we partner with maternal fetal health And it's a long-winded answer, Michelle, just that nobody's going to win the safe care of women by all of a sudden waking up and thinking this is a time to start aligning partnerships. So I think that this needs to be a long game that wise health systems will do. And in the short term, then to start really aligning. So from a clinical point of view, we have a Center for Maternal Health. And many of these clinical issues, remember, almost 20% of pregnancies ends up in miscarriage. Miscarriage can present with catastrophic bleeding or infection that can really put the woman's life at risk. So from a clinical point, and then the ability to give an individual, a pregnant person, all medical options
Hmm.
for a good and healthy outcome need to be available. So from a clinical point of view, we're sort of doubling down on maternal health and all of the medical options through a multidisciplinary approach. We then partner with our corporate leads, with our finance. We have historically, as most health systems do, have important partnerships with local community groups, religious, not-for-profit, education, but also with government officials. So in New York State, we've had a long-standing relationship with leadership up in Albany, as well as leadership in our 5 boroughs of New York City and Long Island. And all of these opportunities are partners that can align to maximize the likelihood of having all medical options available for all people.
Absolutely. Very well said. And it does look like our chat is coming in with a few questions, if you don't mind. Peter Wright is wondering if this crisis in access will lead to new ideas about how to break down barriers for telemed and at-home options. He says, clearly there are still major risk issues, but how will innovation take hold here?
Yeah, we, as many of you who've lived through COVID, like to only half-heartedly joke that you never want to waste a crisis, right? That the nature of my practice as a women's cardiologist has changed in a positive way since the pandemic crisis. There's things we learned. It forces us to look outside of the box. I think now would be an enormous time to identify new approaches, even new opportunities to go upstream with further education, um, further partnership, again, whether it's faith-based initiatives or school-based. I would argue that, we expect high school graduates to read Shakespeare, which is wonderful, but nobody finishes high school, a public school in New York State, health literate. I mean, now is the time to, perfectly well said, to use this crisis for an opportunity to create new processes, new partnerships, new avenues. I hope you're right, because frankly, we do better as healthcare leaders, as we did during COVID, when we had no choice but to figure it out.
Absolutely. Very well said. Um, Dr. Rosen, how or what are the long-term effects on residents and clinical training that you see from all of this?
Yeah, it's pretty catastrophic. The American College of OBGYN has called it a brain drain. So again, not to trivialize, but during my cardiology fellowship and my training and career, I learned all different options. So the surgical ability to technically do an evacuation in an 18-week pregnant woman who is bleeding or is severely infected is a surgical skill that is life-saving.
Hmm.
And unless you are trained to do these procedures, and unless you are working with individuals who can teach you, even in the infrequent occurrence, then you become a physician who's not able to do your job optimally.
Yeah.
The rumor mill around OBGYN colleagues of mine who train the next generation is that some of their, new graduates don't want to work in certain states. So if I were an obstetrician gynecologist, I'm not sure that I would want to work in a state where I couldn't do my best for a patient's choice, if I couldn't um, not be interfered in an exam room with a lawmaker or an attorney or
Right.
and so I can imagine some really worst case scenarios of this inability to be sure that the next generation of obstetricians, family medicine doctors can really take care of women optimally. This is a guideline-based, effective, safe option for women in certain situations that leaves very little choice. There are cardiac conditions that the mortality quoted for women with certain conditions could be as high as 50, 60%. Could you imagine? And some of these conditions we don't know till the woman, conceives. Contraception is not perfect. Imagine not being able to have that conversation with a patient in your office
Right.
who shows up with severe pulmonary hypertension and a 6-week pregnancy. It's
Absolutely.
unacceptable.
For sure. And I read a stat that 44% of the nation's current OBGYN residents are training in states that have now banned abortions. So
Right.
we're
So
not
that's, yeah,
talking about an insignificant amount of people here. So,
yeah, no, Michelle. And they're being trained by a smaller and smaller cohort of experienced, surgeons and clinicians than 40 years ago.
right. Absolutely. And what about the gray areas that this law is kind of going around, like ectopic pregnancies, miscarriages, DNCs, IVF? What are you seeing in those spaces?
Yeah, from the clinician and utter um, anger and exacerbation,
Yeah.
because this is healthcare. These are healthcare decisions. An ectopic pregnancy is when the embryo or group of cells inadvertently implants in a tiny tube that leads to the uterus, and the woman's uterus is made for a pregnancy. An ectopic pregnancy, if undiagnosed, will lead to death, or need for acute hysterectomy and septic shock. This is a big deal.
Mhm.
And to take off the list of options that a clinician has for something like an ectopic pregnancy, infection during pregnancy, and these things aren't rare, honestly, and the whole conversation just is so intrusive into the doctor-patient relationship that we need to bring this back to this being healthcare.
Absolutely. I 100% agree. And thank you all for keeping a very active chat. We do have another question from Steve Miff at PCCI. So Steve is asking, how are multi-regional health systems approaching this, given that so much of this becomes local? How much system coordination while accounting for local dynamics?
No, that's a fabulous question. And interestingly, you would ask that question about anything, that a large multi-centered health system, right? We've got 23, at least as of this morning, hospitals and 3,700 clinicians,
Mhm.
doctors, more nurses. I think, again, it speaks to how we do it with everything. It requires a systematic approach to leverage the assets of advocacy, government relationships, even philanthropy, honestly, to support some of these unpaid for services that we know we need to provide. But then, like everything else in healthcare, you have to bring in local leadership, local partnerships to be sure you optimize good outcomes. How we would manage this, I would say, in the Upper East Side of Manhattan next to Lenox Hill may have a different flavor and feel for how we might do it in Cambria Heights and Queens, a very heterogeneous community with a very high rate of people living below the poverty line.
Sure.
So I think, like every other thing that we do well, the local, state, federal government each needs to have its role, and I mean that in parentheses, not our actual local, state, and federals, but your local, state, and federals. How you manage challenging and complex issues really needs to be aligned, but then customized for the region. And not for nothing, that's kind of what I do in my office, and that's kind of what you want me to do in my office. So
Sure.
if we think of abortion services as healthcare, that message needs to be customized for the patient in my office.
Absolutely. How are you expecting the OBGYN volumes to change, specifically since you are in New York and they are still allowing abortions in that state. How are you guys kind of bracing for impact if other people from other states are coming to you?
Yeah, as we said, we're looking at our care model to be sure that those who we have who are family planning experts have the capacity to expand their clinical output if they need it. We are looking, though that will take a year or two, to expand our training opportunities to bring more, fellowship trained clinicians into the world. And we're looking at the finances to be sure that we can offer these services in a way that doesn't let costs be a deterrent to the right thing.
Yeah, that's taking a lot on your health system to
Yeah.
just provide this support. So props to you guys for doing that.
Yeah, I mean, at the end of the day, if you take out all of the overriding drama, this is fundamental to women's health. And it's complicated. Lots of what we all do, right? Everyone on the call with us is complicated, but that's why we need to do this right.
Yeah, absolutely. So you kind of alluded to it earlier, but what are the key consequences to an OBGYN brain drain in certain areas of the country that you're expecting?
Yeah, poorer health outcomes for women. I mean, the cover of the Lancet said that there will be blood on the hands of people who, and that is a really provocative statement
Yeah.
for a highly academic medical journal. That you will have poorer outcomes for women. Women are the bedrock of their families, so you will have poorer outcomes, both health-wise, increased mortality, but also, women who are denied abortions live below the poverty line. You look at the economic repercussions of this change in the law, and it spirals down to how well families can actually sustain and live, and how they then support the next generation. So imagine that you have states where new doctors don't want to work. And then all of a sudden, rural health is challenged already when it comes to maternal care and chronic disease care. And then you have physicians who may not be experienced or comfortable doing some of these life-saving procedures. And so you could clearly see the dominoes falling on the negative impact this has on women's health. And
Absolutely.
not for nothing, when we do badly for individuals and don't keep them out of hospitals and healthy, that is grossly put a financial drain on our healthcare, because these unnecessary costs could be avoided.
Right. What a statement for 2022 and the world we're living in, that, um, this is where we're at. But okay, so how do you expect this will affect the patient-physician relationship moving forward?
I'm practicing 31 or 32 years. I have a daughter who's a doctor, and when she was interviewing for medical school, some people said to her, "Oh my God, your parents are both doctors and they're letting you go into healthcare." For any of you with adult children, you know that we are not in charge. And I only practice 20% of my work week, but when I walk into an exam room, it is a sacred space for me. It is a place where people undress who I've never met. They share substance abuse stories. They share infidelities. They share challenges in their life. That is the most sacred relationship that I've ever had. And my job is to sometimes hold their hands and give them all of the information I have, sometimes disagree with them, but respect autonomy. So I think the idea of being told what I can and cannot do in my exam room, or for my colleagues, my OR or my emergency room, it is an unimaginable, demoralizing and almost moral injury to clinicians. I disagreed with the decision my patient made when we found out she was having twins. And if everything were to my choice and I got to make the choice, I would have recommended terminating the pregnancy. She had lost a pregnancy at 22, 23 weeks. She had almost lost her life that time, and it didn't seem that we had gotten her underlying chronic condition. But that was not my decision to make. But
Sure.
I did have the opportunity to speak to her and her family, bring in experts, and sort of hold her hand as she made the decision. And, that's what respect for a person's autonomy means to us. And it's at
Right.
the core of what we do.
Right. It's now been rattled and shaken.
Yeah, sorry to be over dramatic, but the idea that lawmakers or others get in that exam room with me, it gets kind of crowded in there.
For sure. What a statement. Um, Jim is asking, you mentioned that Northwell was looking at the long-term view. Can you share more aspects of that view that other health systems might consider?
Yeah, no, absolutely. I think their commitment to women's health writ large is a long-term view because it goes away from just focused on, how many bypasses we do and how many hip replacements and because ultimately we know we're going for a world where we're paid for our quality and valued for, good outcomes. And so setting up a women's health institute is a long-term view. Setting up a maternal health center for maternal health. It's particularly focused on Black maternal health.
Sure.
Black women die 3 times as much in childbirth as whites or non-Blacks. That to me is the long term. It's looking at how we, as Michael Dowling says, how we raise health, not just do more of stuff to a community. And I think going upstream to prevent some things is often a costly investment at the start. It's also very hard. But I think it's these challenges are some of the novel approaches that I think we can do as a profession.
That's so true. Absolutely. Well, I'm leaving 5 minutes here for any Q&A if anybody would like to unmute themselves and ask Dr. Rosen anything that's been on their mind. Do we have any other questions here?
Michelle, should I just take a look or
Um,
tell me what's easier?
oh, here we have one. How is this impacting psychological safety of the clinicians on top of navigating through COVID-19?
Listen, it's horrible. The head woman ultrasound, the imager, the radiologist who does this, and the head of maternal fetal medicine, high risk OB, had said to me that they, dozens of times a week have these conversations, a profound fetal anomaly that they see, or a woman who comes in bleeding. And I don't use the term moral injury lightly, but the idea that on top of everything that the healthcare world has been through in the last 2.5 or 2.25 years, to now for those in the women's health field to have another set of challenges, navigations, uncertainty, it's tough. It's tough when you're asking the head of MFM to just be allowed to do his job.
Yeah,
He has saved the lives of hundreds of women over a lifelong career, as his colleagues do. And we all see this as healthcare. I don't mean to arrogantly say get out of our way and let us do it, but don't make it harder.
sure. Well, Dr. Rosen, thank you so much for being here. I know this was truly valuable for us and a lot of our attendees. So we want to say thank you for being the first speaker on our community call.
My pleasure. It was a pleasure. And I think that the brain power of all of us in healthcare, corporate healthcare, is what will get us through this, kind of dark and challenging time. We kind of don't have a choice, right?
Sure, sure. Well, thank you so much for your input. We do have another one of these community calls coming up in a month. So look in your inboxes for an invite there. That's on the economic downturn and how that is supposedly going to affect digital health one way or another. So be on the lookout for that. And thank you all for being here. This was such a lively and great discussion. So hope to see you all soon and have a great rest of your day.
Thanks all.
All right. Thank you. Take care.